This lecture is going to focus on diabetes, mainly type 1 and type 2, but we are going to discuss also gestational diabetes. The next couple of slides, you're going to have a couple of questions just to kind of prompt your thought process of diabetes. And the answers are located in the notes section of the PowerPoint. But the first one is which tissues require insulin to enable movement of the glucose into the tissue cells? And it's a select all that apply. The correct answer is C and E. Adipose tissue and skeletal muscle require insulin to allow the transport of glucose into the cells. Next question, what characterizes type 2 diabetes? It's also a select all that apply. The answers are A, B, C, and D. Type 2 diabetes is characterized by beta cell exhaustion, insulin resistance, genetic predisposition, and inherited defect in insulin receptors. Which patient should the nurse plan to teach how to prevent or delay the development of diabetes? The correct answer is C. Type 2 diabetes has a strong genetic influence, and offspring of parents who both have type 2 diabetes have an increased chance of developing it. Analyze the following diagnostic findings for your patient with type 2 diabetes. Which result will need further assessment? The correct answer is A, an A1C greater than 6.5%. A1C measures the amount of glucosate hemoglobin over a 2 to 3 month time frame. So, what is diabetes? It is a chronic multisystem disease characterized by hyperglycemia, which is abnormal insulin production or abnormal insulin use. In the US, there's an estimated of 34.2 million people that are diabetic, which is 10.5%. It's pretty high. 86 million have prediabetes, so they have no clue that they have it. And those that have diabetes are at risk for heart disease and or stroke. They're 2 to 4 times greater than anybody else. So those are, I think, some pretty staggering statistics. So the pathophysiology of diabetes, it's a it could be genetic, autoimmune, or environmental. It is a disorder of glucose metabolism related to an absent or insufficient supply of insulin. And there's 4 classes. The most common are type 1. Type 1 is the autoimmune, and type 2, diabetes. The others are gestational diabetes, and sometimes we can have some that are specific type secondary to medical condition or treatment. Some medications you'll find will increase the blood glucose in a patient's blood. And so you see this sometimes where patients are in the hospital and you're having to take Accu-Checks, before they eat, and they're saying to you, I'm not a diabetic. And no, they're not. But because of medications that they're taking, it is increasing their glucose. Therefore, they might need insulin just while they're in the hospital. Once that medication is no longer being used, then the patients do not have the Accu-Check, therefore they won't need the insulin. Insulin is a hormone made by the B cells and the insulin of Langerhans of the pancreas. Cells break down glucose to make energy. The liver and muscle cells store excess glucose as glycogen. The rise in glucose after a meal inhibits glucogenesis, enhances fat disposition of adipose tissue, and increases protein synthesis. So prediabetes is defined as impaired glucose intolerance and or impaired fasting glucose. Blood glucose levels are elevated, but they're just not quite high enough to meet the criteria. So oftentimes they're typically asymptomatic. The patient doesn't have any episodes or any issues with hypo or hyperglycemia, but long-term damage is currently occurring, especially in the heart and blood vessels. Patients who have prediabetes are at a risk for developing type 2 diabetes. So we want to educate to try to prevent or delay the development. So things like maintaining a healthy weight, maybe having an exercise program that they're involved with, whether that's walking and a few times, 3 to 5 times during the week. Maybe they go to the gym. Maybe they do spinning classes, whatever works for them, but incorporating some type of exercising and then really teaching them about making healthy food choices so that we can delay this because the longer that we can delay a patient getting to the diabetic criteria, the better off the patient is. But they're also reducing some of the damage that is currently happening while they're not necessarily meeting the criteria of diabetes. So type 1 diabetes is an autoimmune disorder. The body develops antibodies against the insulin. So they just don't have it. They will forever, lifelong be on insulin. There is absent or minimal insulin production. The pancreas is just not necessarily making it. The onset, it's more common in young people. However, it can occur at any age, but we do typically see it that they're diagnosed as younger people. The onset is signs and symptoms are rapid, and initially, what happens is the patient comes in and they have DKA, diabetic ketoacidosis. And so they come to the hospital, and that's generally where they end up with a diagnosis of type 1 diabetes. Like I said, they require external insulin to sustain life. They must have that. The risk factors for type 1 diabetes, there is definitely a genetic predisposition or exposure to a viral infections. Um, Sometimes it's idiopathic, so that's most often in African Americans, Hispanic, or Asians. Uh, so the type 1 diabetes clinical manifestations, like I said, it's an acute onset. They have the three cardinal signs, classic symptoms, which are the three P's. So they have polyuria, meaning I pee too much, I drink too much, polydipsia, and then polyphagia, I eat too much. So I drink too much, I eat too much, and I pee too much. Weight loss may occur. So with type 1 diabetes, which is a complete comparison to type 2 diabetes, these individuals are usually thinner. They don't necessarily, they're not usually overweight. Um, so the body cannot get the glucose and breaks down fat for energy. And this is part of the reason that they end up being a little thinner. They have weakness and fatigue um, due to the cells lack of energy from the glucose. They have an increased frequency of infection. Um, so uh, these are usually the clinical manifestations that you will see with a type 1 diabetic. So for type 2 diabetes, these patients have an inadequate insulin secretion and insulin resistance. So to contrast that to type 1 diabetes, who they just don't have it, um, they're just not, there's an inadequate amount of insulin secretion, and they could have insulin resistance. The pancreas does still make the insulin, but it's just not enough. The onset is usually very gradual, and oftentimes people go undetected for years and years and years. Symptoms of hyperglycemia develop when 50 to 80% of the B cells are no longer secreting insulin. So by the time that they get a diagnosis, um, the average person has had diabetes for 6.5 years. So, and they may actually start seeing like complication of diabetes, but not really attributing it to it. But they do start exhibiting some of the complications that we'll discuss a little bit further. So there's some risk factors for type 2 diabetes. So somebody that's overweight or they're obese, um, oftentimes we find that as people advance in age, they tend to fall into the type 2 diabetes because of lifestyle choices before. It can also be because of a family history. So if a mother, if a brother, a father, a grandfather, if they have diabetes, there is a predisposition to that. We do find it most more prevalent in ethnic populations, and you can kind of see the breakdown. Native Americans at 14.9, African Americans at 12.7, Hispanics at 12.1, Asians at 8.0, and whites at 7.4%. So some of the clinical manifestations for type 2, sometimes they're just nonspecific, but they will have those cardinal three Ps, the polyuria, polydipsia, polyphagia. Again, I eat too much, I drink too much, I pee too much. More common associated with type 2, they can have fatigue, reoccurrent infections. They can have like yeast infections, vaginal yeast infections, candida infections. So that could be like yeast in the mouth. Um, Prolonged wound healing is often what we see with patients. So they have a sore or something, usually in the lower extremities, and it's just really taken a long time for that wound to heal. And it's because of the damage that has occurred to the capillaries and to the blood vessels. And so what has happened is that nutrient-rich blood is just not reaching those areas that really need it in order for that wound to heal. And then they can have some vision problems. So oftentimes you'll find that patients will do their annual eye screening, and it's the ophthalmologist that oftentimes will say, "Hey, look, I'm noticing some changes and the structure in the eye. There seems to be some signs that it's showing me that potentially you've got some damage to the retina area. So I think that you need to." Follow up with your physician and get screened for diabetes. So sometimes these people who are asymptomatic, it does come through with their eye exams, and the doctors are recommending them to get further tested. Okay, so this is just a nice little image that kind of shows you the differences in the altered mechanisms between type 1 and type 2. Kind of gives it all in a little nutshell so that you can see that the type 1 really is about the autoimmune destruction of those B cells and that they have the insufficient production of insulin. Again, these particular patients are going to be on insulin for their lives. They do not have any chance of coming off of it. Type 2 diabetes is a little different. We just have that we have the defective B cell secretion of insulin. Um, we have insulin resistance that stimulates increased insulin secretion, so we've got more insulin, and eventually the exhaustion of the B cells in many people. So they tend to have more weight. There's a there's this altered glucose and fat metabolism. Excess glucose is production is happening in the liver. And then there's like an inappropriate regulation of the glucose production. And then we have in the muscles, we have defective insulin receptors, insulin resistance, and decreased uptake of glucose by the cells, resulting in hyperglycemia. So gestational diabetes, it develops during pregnancy in about 2 to 10% of people in the United States. These pregnant mommies are at a higher risk for C-section, some type of birth injuries, perinatal death. Uh, that's why we do a screening. The screening usually is around 24 to 28 weeks during the pregnancy. They make the patient drink this like it reminds me of like a flat orange soda, and you have to take readings. They take your blood sugar readings at several different times throughout the test, and they will determine whether or not that you have gestational diabetes. Women with a history of gestational diabetes have a 63% greater chance of developing type 2 diabetes within like 16 years. So if they have gestational diabetes or had it when they were pregnant, they do have a higher predisposition to potentially get it later on in life. And of course, risk factors being obesity, advanced maternal age. So you're usually looking at somebody who's over the age of 35 that's having a baby, and then if there's any family history of diabetes. Some other types of diabetes can be secondary to medical condition or treatment. Um, some conditions would be like Cushing's disease, hyperthyroidism, and pancreatitis. These are some conditions that can cause it. Medications such as corticosteroids, um, thiazides, Dilantin, and antipsychotic medications. They usually resolve, meaning the patient doesn't end up needing insulin or anything like I had said previously when the underlying condition is treated or medication is discontinued. So if the patient's no longer taking corticosteroids, that's usually the one, honestly, that I've seen in the hospital quite a bit. We stop giving it to them, and then they no longer are really classified as any type of diabetic. So some diabetes diagnostics, there's four methods. We usually use A1C, and if that is 6.5 or higher. Um, and we also look at it for prediabetes, right? So we're looking at people so that we could maybe make some modifications, maybe with lifestyle choices, food choices, maybe weight loss. So prediabetes would be in the 5.7 to 6.4%. Another method is the fasting plasma glucose, so the FPG, and if that level is 126 or greater. A 2 hour plasma glucose level, those are usually the ones that we look at with pregnant mommies, and if that is over 200 milligrams, then that's another diagnostic. And in a patient with classic symptoms, a random plasma glucose of 200 or greater. So these would be some of the diagnostics that we would use. I believe on page 1289, table 53.2, uh, goes over the diagnostics. So when we look at the diagnostic assessment, of course, we're always going to ask about H&P, right? Do they have a family history of it? Do they have a mother, a father, sister, brother, anything like that that has diabetes? We'll look at some labs that are diabetes specific. We're going to look at the BUN creatinine, electrolytes. We'll look at a lipid panel, and then we'll look at the insulin cells, autoantibodies, especially if we believe that there is some hereditary component for type 1 diabetes in the antibodies. We'll look at a urine specimen. We can look and see if they are breaking down protein, and we'll see protein in the urine. Fundoscopic exam is a comprehensive exam that checks for eye damage caused by diabetes. We can do a neurological exam and look for neuropathy, especially in the lower extremities. So we're really looking at the lower ankles, feet, those areas. So we can have a podiatrist look at their and do an exam that way. And then, of course, we're going to look at monitoring weight and see what has that look like? What is it like now? Have they lost weight? Have they gained weight? Anything like that. So those are going to be some of our diagnostic assessments. With our diabetes management, some of our goals would be to reduce some of the symptoms, promote well-being, and prevent any acute complications related to hyperglycemia or hypoglycemia. We want to prevent or delay any onset or progression of the disease or long-term complications. I cannot stress enough, the patient education is just key. It is absolutely key. So, nutrition wise, again, maybe consulting a dietitian to help a patient to pick better foods. How can they incorporate some of the healthier foods into their lives? Medication therapy, if that is in fact something that they have to do, what patient education would we need to provide? And then looking at exercise and physical therapy, it's really recommended for about 150 minutes a week. And then self monitoring. So, that's things like checking um, their blood sugar levels, knowing how to do that properly. Those are some educational pieces that we would need to do. Nutrition wise, on page 1300, table 53.9, um, monitoring carbohydrates, that's a big deal. People don't really realize. I can tell you, my mother, who's not a diabetic, but her blood sugar fluctuates a little bit. And I'll say to her, your, A1C is up a little bit. And she'll say to me, I haven't been eating all that candy. It isn't just about candy. It's carbohydrates. It's rice. It's potatoes. It's bread. It's those things. And oftentimes people really don't understand that. We're looking at the fat content, protein. Um, we might need to talk to them if they tend to drink alcohol, that limiting that consumption to maybe one drink per day for women and two per day for men, because that also can increase your blood sugar level. So diabetes management, the medications, there's three types of glucose lowering agents. So GLAS. So there's an injected insulin. They can be an oral agents or they can be non-insulin injectable agents. Exogenous insulin is used when a patient has inadequate insulin to meet the body's needs and they need insulin from an outside source. Oral agents, kind of like a metformin, non-insulin injectable agents, they do have some inhalation ones that can be used. So there are some different types. This image should be, our table should be really something that you remember from first semester. I believe when you were in your essentials class, the lab, you learned about insulin and rapid, short, intermediate, long, and inhaled insulin. And so I believe it's on page 1291, figure 53.4. I would know the onset, peak, and duration, and what is classified as the rapid, short, intermediate, and long. Um, Rapid acting, we're looking at Lispro, so Humalog. We give this often when you're in clinical. I'm sure you've seen lots of patients that end up having this. This is usually the one that we give for. We take the blood sugar level, right? We do the AccuCheck. We get the reading, and based upon whatever the scale is, the sliding scale, whatever the doctor has ordered, we administer usually like a Humalog. What's important about knowing about the rapid acting is that the onset is very quick, right? It's 10 to 30 minutes and it peaks at 30 minutes to 3 hours. So, why is this important? It's important because if you have to give this medication, say for instance, um, for in the morning, and it says that it's ordered to be given at 7 o'clock in the morning, and your breakfast trays are not coming until 8 o'clock. Don't give that medication to a patient at 7 o'clock in the morning. It is going to start working and your patient is going to end up hypoglycemic. So you really, you'll notice that a lot of times nurses will time it. They know about when the trays are coming, or they might, in fact, get somebody a snack or something. They need to eat. If you do not feed your patients after administering this, the chances of hypoglycemia episodes increase. Short acting, like the Humulin R or Novolin R, they have an onset of 30 minutes to 1 hour and they peak in 2 to 5 hours. Intermediate, Humulin N, Novolin N, and then the long acting, you'll see these are like Lantus, Levemir. So these have a zero point 0.8 to 4 hour onset, but these are actually like the ones that you'll give. It seems like a higher dosage. Um, but they just kind of like lay out there in the background and kind of take care of things. It's not as fast of an onset of it. So you'll see oftentimes that patients have long acting and a short acting or a rapid acting insulin as part of their medication regimen. So storing insulin is definitely a concern. So, I wouldn't tell my patient that it's okay if they put it in their car and leave it in their car all day and take their insulin. Most of the time, it needs to be um, in, like, especially if it's the vials, they need to be in the refrigerator. They're usually in there and then they're brought out. Uh, Extreme temperatures make insulin less effective. Um, Vials and pens may be left at room temperature for up to 4 weeks. Sometimes people will put them in the refrigerator to prolong it, but you need to kind of, if they are not using it. So if you pick up the prescription and they've got, four vials or something like that, then you want to make sure that you refrigerated those unopened vials. Avoid direct sunlight exposure, so they don't need to be sitting on the windowsill, and any type of pre-filled syringes, um, they need to be stored upright, and you would need to roll them, not shake them, but roll them before the usage. Uh, the hospitals that I worked at, we often had just the vials, but I know that a lot of other um, facilities have the pens, and I think we talk about the pens here in just a little bit. So insulin administration, it's given by subcutaneous injection. I always say that it's kind of like in the little fatty areas. So, our little love handles, right? They can be on the back of the arms, it can be at the top of the thighs. So, we're looking for areas that have a subcutaneous fat. Um, they do absorb better in the abdomen. We would not give IM because of the increased risk for hypoglycemia. However, we can give regular insulin by IV, and we do it by drops. Uh, at one point in time, I worked in a pre open heart surgical unit. And so, patients, before they're going into surgery, they typically go on an IV drip, and then we have to monitor it. We're literally taking Accuchecks like every 15, 30 minutes so that we can turn around and change the dosage as needed. Um, no PO inactivated by gastric fluids. And like I had said, the absorption is fastest in the abdomen. So this is just a revisit. I'm sure you've seen this before from first semester in the areas in which we can inject. If a person is self-injecting, obviously it's a little harder to do it on their buttocks or on the back of their arms. So we tend to do it in the abdomen or upper thigh. The abdomen, it's just important that we rotate the site. That's why we don't give it in the same location each time. We go from one side to the other. We do it, a little higher, a little lower, but we make sure that we stay within outside of 2 inches from um, the belly button. So make sure that when you're administering, those are the areas. So insulin injection, so they can be self-injection or they can be that insulin pen like I was talking about. And I know some hospitals use that. The self-injection, the only users recap the syringe. Um, you would want to make sure that they clean the area, they wash it with soap and water, they use an alcohol swab. If you're administering these in the hospital, you want to follow your policies and procedures, which is usually clean the site with alcohol, let it dry. You certainly wouldn't blow on it, you wouldn't fan it, you just let the alcohol dry. The insulin pen, one of the nice parts about it is that it provides consistent, accurate dosing. It's also portable, convenient, it's compact, it's discreet. There's various lengths and gauges of the needles. It's a good option for patients with decreased vision, and patient education and printed instructions should be absolutely given to them if this is the first time that they're using it. Quite frankly, if it was the first time I was giving somebody, um, like they were being prescribed the insulin pen, I'd make sure that they know how to um, look at, understand the pen, understand how to administer, and I would do a teach back and have them demonstrate for me how uh, that they would administer the medication. Insulin pump is a continuous subcutaneous infusion of rapid acting insulin. It's small, it's battery operated. The device is connected to a catheter inserted into subcutaneous tissue in the abdominal walls. Some pumps they don't have tubing, they're tubing free. Um, Patients would need to change the set and the site every 2 to 3 days. There's a program for basal and bolus doses that increase or decrease throughout the day based on the carbohydrate intake, the activity, potentially illness. Uh, they check the glucose 4 to 8 times a day, or they have continuous monitoring. Some of the major advantages is that it keeps blood glucose in a tighter range. You avoid the highs and lows. We don't want that. Um, and there's careful programming and consistent monitoring makes it possible because delivery is similar to physiological patterns. There's more flexibility with meals and activities. Some potential concerns with the insulin pump is infection at the insert site, the risk for DKA, the cost of the pump and the supplies, and the attachment to a device. Um, Now I think there's so many of these insulin pumps that they have programs right on your cell phone. So shoot, you can put those little patches on, take your phone, go near it, and it actually does your readings for your blood sugar, which I think is amazing, especially if you're having to they wear the pump in the little pods um, that they have. So this is probably one that you might have seen people actually even out in public where you see the little pods on them. It's the Omnipod insulin management system. It just gives you a good visual of what these potentially look like, what's attached to the body, and then whether it's your cell phone, your smartphones, that then do the reading, or if you have an actual device is that is connected with the Omnipod. So there is an inhaled insulin. I actually have never seen one of these before, but it's a rapid acting inhaled insulin administered at the beginning of a meal or within 20 minutes. Typically, it's used in that combination with a long acting insulin, like I was talking about earlier. Um, the adverse reactions would be hypoglycemia, which we have with all insulins. Obviously, because if it's inhaled, there could be some irritation as far as the cough, throat pain, or any type of irritation with that. We do not use these for people that have DKA, people who have smokers, asthma, or COPD, and I think that you could probably understand why, because of the issues or concerns that we have with the respiratory system not functioning properly. This would not be a good choice for them. So, of course, we're going to have some problems with insulin therapies. Um, you want to assess patient treated with glucose lowering agents. I believe your textbook, I'm sorry, I don't have the page, has a chart about it. So if they're newly diagnosed or if you're doing a reevaluation of the regimen, you want to make sure that you're really going through all of the follow up, making sure that they understand how to use it, why it's used, the proper way of using it. Um, some others with follow ups, so effectiveness of the therapy. There could be some side effects of the therapy, self management behaviors. Are they actually checking their glucose like they're supposed to? Um, we'll get into hypoglycemia in a few slides ahead. Allergic reactions, so we can have local or systemic, and that it's rare, but it can happen. Um, they can have, if they have a latex allergy, so if they're have an allergy because of the mechanisms of the syringes, they can have loss of fatty tissue, that lipodystrophy, atrophy or wasting of fatty tissue. So this is one of the reasons that we do uh, that and the hypertrophy, the thickening of the subcutaneous tissue. That's because we're overusing specific areas and like re-injecting in the same location all the time. That's why we rotate them. And then we can have the Simoji effect. A high dose of insulin causes a decrease in glucose during the night, and the release of counter-regulatory hormones causes rebound hyperglycemia. So the concern when glucose checked in the morning and insulin is up, it's given. So their blood glucose is increased, insulin is given. That's a problem because it will then rebound. You determine if this Simoji effect by checking glucose between 2 to 4 a.m. And you'd also assess the patient for things like a headache, night sweats, or nightmares. There is the dawn phenomenon, which is morning hyperglycemia present on awakening. It may be due to release of counter-regulatory hormones in pre-dawn hours, growth hormone and cortisol to be exact. It's more severe in adolescents and young adults, peak time for growth hormone. So that's those are two different effects, the Simoji effect and dawn phenomenon. I definitely would make sure I remember those two. So diabetes management pharmacology, there's several oral agents. They work to improve the mechanisms by which the body makes and uses insulin and glucose. They work on three defects of type 2 diabetes: insulin resistance, decreased insulin production, increased hepatic glucose production. They can be used in combination. Metformin is the most effective first line treatment for type 2 diabetes. It's available as immediate release, extended release, and liquid forms. It reduces glucose production by the liver. It enhances insulin sensitivity, improves glucose transport. It does, it may cause a weight loss, and it's used in prevention of type 2 diabetes. The one thing about metformin that we need to remember is that if a patient is undergoing surgery or any radiological procedure with contrast medium, it needs to be held a day or two before and at least 48 hours after, um, when the serum creatinine is within normal limits. Metformin is contraindicated for renal, liver, cardiac diseases, lactic acid doses. Iodine-based contrast medium can cause acute kidney injury, and we would also make sure that somebody doesn't take it. It's contraindicated for somebody who has excessive alcohol usage. Uh, Sometimes people can get upset stomach this medication, so it's important that we instruct them on they can take it with food to minimize the GI side effects. Sulfonylurea, sulfonylureas, the action is increases insulin production from the pancreas. A major side effect of these medications are hypoglycemia. Uh, so some of them are glipizide, uh, glyburide. Those are a couple of the examples. Um, Megalitides, um, their action is increase insulin production for the pancreas, and it has a rapid onset, decreases risk of hypoglycemia. Some patient education for this one is to take 30 minutes to just before each meal to mimic normal response to eating. Do not take if you have skipped a meal. So those are a couple of the medications. Okay, so for our nursing assessment, of course, we're going to look at past medical and health history, any type of current medications that they're presently taking. I would also ask about any over-the-counter, any um, herbal supplements that they might be taking. Find out about functional health pattern, symptoms consistent with diabetes. If somebody was complaining about feeling pins and needles in their feet, a wound that's not healing, um, maybe they're having any of those the three P's that we talked about, that they feel like they're just super thirsty. They're eating a lot, they're drinking a lot, they're peeing a lot. I mean, flushing out a lot of urine. And then, of course, you would do a head to toe assessment. It is very important that you do head to toe and that you look at the backside. You're looking for any type of wounds. I would definitely look in between toes, look on the bottom of toes, look at heels uh, during your assessment so that you can make sure that you've covered any type of wounds or anything that the patient might potentially have. So, our nursing management, of course, we're going to do a thorough assessment and education for the patient. We might need to consult other team members. So, diabetic educator, which usually most hospitals have one, a registered dietitian, you can consult them as well. Physical therapy, occupational therapy, social worker. I would also recommend bringing your social worker in because sometimes the medication, as far as cost of it, supplies for it, those are things that the social worker usually has information about different programs that are available. Um, Exercise, again, essential. How do they monitor for hypoglycemia? Um, so, we need to give them their signs and symptoms of that. Um, they should know how to administer their medications, signs and symptoms, hyperglycemia, um, and any type of compliance issue, and then self monitoring of blood glucose. A diabetic patient should check their blood glucose every 4 hours during times of illness. If greater than 240, they need to check their urine for, we need to check their urine for ketones every 3 to 4 hours to make sure that they're not breaking down. Um, Two consecutive glucose levels greater than 300 or moderate to high urine ketone levels should be reported to the healthcare provider. Increase insulin for type 1 diabetes to avoid DKA, especially if they're not feeling well. Increased glucose increases risk of infection and reduces that healing. Um, Critically ill patients may have a higher target goal. So, sometimes we might have, your body's response to stress can raise your blood sugar levels. So sometimes you might see it at 140 to 180. May get insulin if glucose consistently greater than 180. So this is some of our management that we do. So nutritional therapy, it's aimed at monitoring the carbohydrate intake. It's funny, I always remember I'd see patients that had, they were on a diabetic diet. That's what it used to be called. And so, people are looking at some of their trays and they might have pancakes. Now they would have sugar-free syrup, but they would have pancakes and they would have potatoes or they might have rice with their meals. And there's this misconception that patients don't need or should not have carbohydrates. And that is not necessarily the case. And that's one of the reasons that they now call the diet a carb controlled. Our goal is to control the carbs. We don't need the highs and the lows. So if we control the carbohydrates, then we're in more of a carb controlled diet and they're getting it consistently. So we kind of keep it level. It's not this high and this low. Remember that it's not one size fits all. We develop individualized plan for diabetes and pre-diabetes. So remember, we have to take into consideration what's the normal things that people are eating. So one of my first questions would be, can you tell me about foods that you eat typically in your diet? Because if I literally tell somebody they've got to cut something out that they eat on a day-to-day basis, they're not going to be compliant. So we kind of need to meet them where they are. And how can we carb control it? Maybe they have smaller portions, and so that they can still have the foods in which they want to eat. There is so many resources available. The American Diabetic Association, that you can find diets and guidelines. Literally, you could probably, this day and age, you could probably go and chat GPT, tell it to develop you a plan that's carb controlled for a pre-diabetic or a diabetic patient, and it would just spit you out like all kinds of breakfast, lunch, and dinner. So, food composition balance, we need to maintain the balance between carbohydrates, fat, and protein. Remember, your brain actually needs glucose to function properly. So, if we eliminate all of that, then the brain is not getting what it needs. Again, we go back to limiting the alcohol, 1 drink per day for women and two max for men. And again, the goal, maintain stable, consistent consistency, and healthy blood glucose levels. Some nursing diagnoses that would be appropriate for these patients would be lack of knowledge, especially if they're newly diagnosed. They don't know what they don't know. So, lack of knowledge definitely. Hyper and hypoglycemia, risk for injury, and impaired peripheral neurovascular function. And this has a lot to do with that neuropathy. So, for planning for the diabetic patients, our overall goals engage in self care behavior to actively manage the disease. I always say that, there's two ways that you can do this. The disease can manage you or you can manage the disease. You managing the disease allows you to take the disease and incorporate it into your life instead of the disease taking over your life. We would like to have few or no hyper or hypoglycemia emergencies, maintain normal or near normal blood glucose levels, prevent risk for chronic complications, which we'll get into here in just a few minutes, and adjust lifestyle to accommodate diabetes plan with minimal stress. Again, learn how to bring diabetes into your life so that you can control it and you can still do the things that you enjoy doing or the patient enjoys doing, without them feeling like, oh my gosh, I can't do anything that I used to do. Learn how to manage it so it can be a part of your life and not take over your life. We're going to talk about some complications of diabetes. So the first one will be hypoglycemia. This is a low blood sugar. This is usually under 70. Um, the body will suppress insulin secretion and produce glucagon in defense. And like I had said just in a previous slide, the brain needs constant supply of glucose to function properly. So this would be why some of our clinical manifestations are neurologic, right? So we have difficulty speaking, confusion. They can have visual changes. They can feel dizzy, nervousness. They can have anxiety. They can have, there can be sweaty. I always say, I don't think I have the slide in here, but cold and clammy, get me some candy. And that's usually with hypoglycemia. My blood sugar is too low. I need to get some candy. I need to bring that blood sugar up. So digging in a little bit further to the hypoglycemia, kind of goes over some of those clinical manifestations that we talked about. The treatment is the rule of 15. So we actually call it like a 15-15. So what it is you take the blood sugar, and if the patient is alert and oriented, okay, um, that we can give them 15 grams of rapid acting carbohydrates. So this would be something like this is what you'll see on the units. They'll have like peanut butter or graham crackers, orange juice, right? These things. We give them 15 grams of rapid acting carb. We wait 15 minutes. We check the blood glucose again. If it's still less than 70, we will do another 15 grams of carbohydrates. If stable and more than 1 hour until meal, give a carb and a protein. If it's still low after 2 or 3 times, you need to call the healthcare provider. If the patient is unresponsive, this is in acute care only. We will give an IV D50 or IM glucagon. When you administer this, if you've ever seen it in the hospital, it is very thick. It takes a lot of effort to push it, um, but this will have a rapid acting. They also have like this gel that you can put in the patient's mouth, and again, it can be a choke hazard, but they can swallow that, and it can actually raise the blood sugar as well. Um, so some prevention: make sure that we take meds on time, coordinate with meals, eat appropriate for the exercise. Uh, Really talk to them about knowing the signs and symptoms of hypoglycemia and how to treat it. They should take simple carbs with them. So in their pocket, in their purses, in their bags, their book bags, they should have things like pieces of candy, right? Like hard candy. Um, so that in the event that their blood sugar goes down, they have something that can help bring it back up. They should also wear or carry a diabetes ID band. And I say that because if somebody has a hypoglycemia episode and they're not alert and oriented and they can't, maybe they've passed out, they won't think that they're in cardiac arrest, right? They'll understand that we need to take their blood sugar. Chances are they need some type of glucagon or D50 if EMS is called. So, what kind of causes hypoglycemia? So, it can be alcohol intake without food, too little food, too much diabetes meds, too much exercise without diabetes medication or food at the wrong time, loss of weight without medication adjustment. So, if somebody's had a lot of weight loss, their dosing will still be on the higher weight. So, we definitely need to adjust for that. It can also be maybe they're on some type of medications like beta blockers that interfere with the symptoms. So the clinical course of it, it's more rapid onset, right? Pattern of manifestations can change over time. Uh, it kind of mimics alcohol intoxication, and if we don't treat hypoglycemia, it can lead to the loss of consciousness, seizures, coma, and also death. So remember the manifestations: blood glucose less than 70, cold, clammy skin, numbness, fingers, toes, and mouth, tachycardia, emotional changes, headache, nervousness, tremors, faintness and dizziness, unsteady gait, slurred speech, hunger, vision changes, and of course the seizures or coma. We would definitely give the treatment of the rule of 15, which I just already talked about, and things that we can make sure that we do as far as preventative: take the medications on time, accurately administer insulin, make sure that you're using the correct syringe. We do not use, we only use syringes that are in units. We use no other syringe in order to administer insulin. If somebody is going to the gym, they need to make sure they eat adequate food. Um, and we have make sure that they know how to recognize signs and symptoms of um, hypoglycemia. And I would also teach the family members. And then, of course, like I had said, to carry the simple carbs and wear and carry diabetes ID. So hyperglycemia, the causes of this could be from illness or infection, corticosteroids, too much food, too little or no diabetes medications, inactivity, emotional emotional or physical stress, and poor absorption of the insulin. So it has a more gradual onset. The definition of elevated glucose varies by person. It's based on personal glucose targets. The manifestations could be elevated blood glucose, increased urination, so that polyuria, uh, the polydipsia, and the polyphagia. Um, we can have increased appetite followed by lack of appetite, weakness or fatigue, blurred vision, headache, nausea and vomiting, abdominal cramps. It can progress to DKA or HHS, some mood swings. Our treatment, they need to get medical care. Continue diabetes medications as prescribed. Check glucose and urine ketones. Drink fluids hourly and contact the healthcare provider if they have ketones in the urine. Preventative measures, take meds as prescribed on time, accurately administer the insulin, non-insulin injectables are OAs. Choose healthy foods, follow the sick day rules so that if it needs to be compensated for not feeling well, check blood glucose routinely. And again, I carry and wear diabetes ID. Okay, so diabetic ketoacidosis or DKA, it's caused by profound deficiency of insulin, characterized by hyperglycemia, ketosis, acidosis, dehydration. This is more likely to occur in type 1 diabetics. So, some precipitating factors, illness, infection, inadequate insulin dosage, undiagnosed type 1 diabetes, lack of education, understanding or resources, um, insulin deficiency. Um, the body burns fat as fuel, so the byproduct of fat metabolism is the acidic ketones that alter pH, so they have metabolic acidosis. Ketones are then excreted in urine along with electrolytes, and it impairs the protein synthesis, causes protein degradation, resulting in nitrogen loss from tissues. It stimulates glucose production from amino acids in liver, leading to further hyperglycemia, and it may cause osmotic diuresis. So, without treatment, severe depletion of sodium, potassium chloride, magnesium, and phosphate, acidosis, vomiting, and further fluid electrolyte losses. Hypovolemia followed by shock may cause renal failure, causing retention of ketones and glucose and further acidosis. Dehydration, electrolyte imbalance, and acidosis causes coma if not treated and then death. I can tell you a personal story about diabetic ketoacidosis. Um, my uh, oldest son had a very, very dear friend, one of his best friends when he was young. And this young man pretty much lived at my house. I kid you not. He lived at my house. And he was a type 1 diabetic. And he did really well. He always took his insulin. He ate me out of house and home. I kid you not. But he always ate like very healthy foods. It was my salads or grapes or all the fruit that I had. But he consistently um, took his insulin very well, no problems. And as he advanced in age, and I believe I talk about it later, I may not, but I'm going to go ahead and talk about it now. One of the major things with type 1 diabetics is there is a psychosocial component to this that oftentimes they have a lot of depression. And there are a lot, and I mean a lot, of different support groups that can help. There's different camps for type 1 diabetes because of it usually being um, diagnosed when they're younger, like, younger children. And so it's very hard for them to adapt, that they're lifelong, that this is a part of their life. And this young man, as they advanced in age and he got into his mid 20s, he really did suffer from a lot of the depressive parts of it. He was tired of always having to check blood sugar and take insulin and make sure he ate. And he didn't feel that he could be the person that he wanted to be. And so then when he was about 27 years old, he just didn't take his medication. And he was in his own apartment and he died. And his last posting on his social media was that I'm tired and I cannot do this anymore. And it was very sad because I really felt that he really needed a support group to help him. But it is definitely something that when we talk about type 1 diabetics, DKA is by far one of the major things that we need to be um, looking at and that we need to educate patients about. And because these patients are usually adolescents, we need to make sure that we educate families as well. So some of the DKA precipitating factors could be the illness infection. And again, that inadequate insulin dosing, maybe they're not taking it. If somebody was not taking enough insulin, this would be something that I would ask them, are they taking their medication as prescribed? And if they say, no, I can't afford it, this is when you need to start looking at talking to your social worker and trying to find out ways in which they can get help because they need this medication. Some other precipitating factors could be that it's an undiagnosed type 1 diabetic. Maybe they have a lack of education, understanding resources, or the story I just told you. So, some of the clinical manifestations, the dehydration, so we're looking at dry mucous membranes, tachycardia, orthostatic hypotension, hypokalemia, so we can look at their potassium levels. Do they have abdominal pain? Are they having nausea and vomiting? Kussmaul's respirations. They can have a blood glucose level greater than 250. ABGs, you can kind of look at the pH 7.30 and the bicarb is less than 16. And then, of course, we'll look at their urine and the ketones will be present in the urine. They also have kind of like a fruity breath. So, some of our management for a patient with DKA, they absolutely need hospitalization. They're typically in the ICU. Um, there's like policies and procedures or logarithms that tell you how often and how to adjust for the blood sugar levels. We usually give them fluids. We'll give them fluids 0.45 to just 0.9% normal saline. Um, Monitor their eyes and nose, how much is coming in, how much is going out. We're going to look at their electrolyte replacement. So we'll, look at like the potassium. Assess the cardiovascular and respiratory status. These patients will probably be on cardiac monitoring. Manage associated symptoms, so anything else that they've got going on. And if it was precipitated because of an illness, we need to treat that underlying illness. Right, so HHS is a life-threatening syndrome. It's less common than DKA, and it occurs with type 2 diabetics. So I do want you to put that together that in most cases, DKA is type 1 diabetics, and HHS is type 2. So the type 2 diabetic is able to make enough insulin to prevent DKA, but still have severe hyperglycemia. Um, the causes are usually um, like an infection, like UTIs, pneumonia, sepsis. Um, it can also be caused by a newly diagnosed type 2 diabetes. Maybe they have an impaired thirst sensation or inability to replace fluids, a history of inadequate fluid intake, enough. There's fewer earlier symptoms lead to higher glucose levels. Usually, these patients are going to have a blood glucose level over 600. You're going to see more severe neurologic manifestations due to the increased serum osmolality. Ketones are absent or minimal in blood and urine. Again, it is a medical emergency. There is a high mortality rate. And then the therapy is similar to that of DKA. So management for where for these patients, DKA or HHS. Monitor the blood glucose, urine for the output and potentially ketones, especially with our DKA patient. We're going to give them IV fluids, insulin therapy. We're going to look and evaluate electrolytes and replace what we need, especially potassium. We're going to assess the renal status. So we're going to look at labs like the BUN and creatinine. We're looking at cardiopulmonary status, and then is there any changes in their level of consciousness? All right, so we're going to look at the macrovascular, microvascular complications. So, diabetic chronic complications, they're usually uh, commonly associated with end organ disease from angiopathy. The macrovascular are things like cardiovascular, cerebral vascular, peripheral disease. It's the leading cause of diabetes related death. So 68% are cardiovascular and 16% are stroke. Um, Macrovascular are the eyes, kidneys, and nerves. They have retinopathy, so there's damage to the retina. Nephropathy, it's the leading cause of end stage renal disease. And neuropathy, so this is sensory and autonomic. 60 to 70% of patients have some degree of neuropathy. So this picture kind of gives you a good idea of all of the different areas that can get affected or be affected by diabetes and why it is so important for us to manage the disease properly. And if somebody is at prediabetes, why we would educate them regarding how to prevent the disease progression. So feet and lower extremities, there is a high risk that patients will have ulcers on their foot in their lower extremities. And because of the wounds not being able to heal, they end up getting um, infected and they become necrotic and gangrene. And we end up having to start with amputations. And you will see that a patient that starts out with um, a toe below the knee amputation, it just continues to keep rising. The results of this is happening because of the microvascular and macrovascular disease, sensory neuropathy and peripheral artery disease, so PAD. Um, they can have loss of protective sensations. So what I mean by that is patients who have neuropathy, um, they are really instructed. Part of our patient teaching is that they should never wear open toe shoes. They shouldn't wear sandals. They should wear closed toe shoes, light socks. And we do that because when patients go barefooted or they wear sandals, they could literally get like a piece of glass into the bottom of their foot or a rock or a splinter, and they don't feel any pain from it. They feel. And so what happens is that item, whatever it is, stays and it keeps on pressing on the skin down there and it punctures it. And then it starts an ulcer. And again, the patient doesn't know. And so it gets infected. Oftentimes they end up with osteomyelitis. And osteomyelitis is an infection in the bone and it is very difficult to treat. It's harsh. We have to use very um, high um, line antibiotic medication like vancomycin that the patient has to take in order to try to treat it. But you have to realize an infection in the bone and how hard your bone is. I have got to penetrate that antibiotic into that so that I can treat that infection. So in the lower extremities, the PAD, so that peripheral artery disease, it reduces that blood flow into the lower extremities, and that is what indeed increases the risk for amputation. The blood flow is decreased. There's slowing healing time. Again, I'm not getting that nutrient rich blood into those areas that need it in order to heal. So infection ends up happening. So What do? We need to make sure that we educate about the proper footwear, like I was talking about. Avoid feet injury. Make sure that you're wearing those closed shoes. Make sure that you are um, inspecting your feet. If somebody is overweight or they're not able to bend down to look at their feet or bring their feet up, then that needs to be somebody within the house, their responsibility. And that's checking between the toes. We clean the feet every day. We clean them, we wash them, we dry them completely, including between the toes. We do not add any lotion between the toes because that can allow for skin to break down, and so we wouldn't want to put lotion between the toes. These patients cannot have, um, you know, us ladies, we love to go get our feet done. Pedicures are the thing, but a diabetic patient should not be somebody that goes and has a pedicure. And the reason for that is because they typically will cut toenails at that time, and their toenails should really be cut only by a podiatrist. So you know when people cut your own toenails or you have them cut and it gets off to the side where that skin is. If it gets stuck, we typically pull it, no big deal. But if you have somebody that has diabetes and you pull that, you've now given it an opening that potentially an infection can occur. If a patient, they need to be educated that if they, in fact, find that they have a wound on their foot or an ulcer or something like that, it needs to be reported immediately and treatment needs to begin immediately. So it's really important that we provide a lot of patient teaching regarding the feet and lower extremity complications. So this is the foot and lower extremity complications. You can kind of see the feet here. That's a necrotic toe on one side, and that's a great big open wound that if you look, looks like it began between the toes. So definitely the macrovascular and microvascular diseases increases the risk for infection and injury. Um, Sensory neuropathy and PAD are the major risk factors. Other factors can be clotting abnormalities, impaired immune function, autonomic neuropathy. Smoking increases these risks. The sensory neuropathy may cause loss of protective sensation, prevents awareness of the injury, and that's a major risk factor for those amputations. The patient teaching, I talked about the foot care, avoidance of any type of foot injury, skin and nail care, and who should or should not be doing it, daily inspection of the feet, prompt treatment of any type of issues, ulcers, cuts, abrasions, anything. And we have to do diligent wound care for any type of foot ulcers. I've seen a lot of wound vacs being used to try to help um, with the healing of these wounds. Um, Sometimes we can get a neuropathic uh, arthropathy or thoracic. It's a joint dysfunction and foot drop, which may cause ulcers as well. There are skin complications, and we see it in two-thirds of the patients. Diabetes related uh, dermopathy, which is skin lesions characterized by like reddish, brown, round little patches. They're scaly, they're flat. Um, they often appear on the shins, but can actually be anywhere. We can have black brown thickening, mainly on like the axilla or the neck. And then you could have yellow or red lesions. And these are just different skin conditions that can happen. Diabetic patients are more susceptible to infection due to that defect in mobilization of WBCs and actually the RBCs as well. Um, Reoccurrent or persistent infections, again, the yeast infections, they can have boils, they can have bladder infections. Again, the psychological considerations, I talked about the depression, anxiety, and eating disorders that can happen. Um, and remember, people who are depressed really do not have good hygiene, and it really leads to them to just kind of let themselves go. And there really is, a, a big problem with people who have chronic diseases and how they really feel that their quality of life is just not very good. And if you feel that one of your patients is exhibiting some of these behaviors of depression or really neglecting themselves, we need to get others involved. Sometimes we have to do a consult to a psychiatrist, um, so that they can come in and evaluate the patient, because we need to do whatever we can to help them, so that we can work through some of the depression or some of the issues that they may have so that they can better take care of themselves. Again, with any chronic condition, it really comes down to, does the manage control you or do you control the disease? And so, um, learning to live with it and control it is, they have much greater quality of life than patients that just kind of let the diseases take over.